introducing Julia Lipsky. She is completing her fellowship in neonatal perinatal medicine at the University of Vermont this year, and then she'll be moving on and leaving us to work in Albany. She completed her pediatrics residency at Dartmouth-Hitchcock, where she participated in advocacy work focused on improving the transition from the hospital admission to an outpatient clinic for families who have substance use exposure. Her fellowship research and QI work at the University of Vermont has similarly focused on understanding barriers to and improving care for families affected by in utero substance exposures. And she is going to share some of her work with us today.
Thank you so much, Dr. Paul. I'm really excited to get to share some of the work that really we've been doing with a large number of the people who are also on the VCHIP team around increasing our referrals and just the background on why home health is so important. So next slide. So these are our objectives for today, really talking about the role of home health, particularly in mental health screening for parents and developmental screening for infants, how we actually refer, because that has come up as a very confusing process. And then I'll talk a little bit about the quality improvement work that we've been doing at UVM. Next slide. And so I want to start just highlighting that this perinatal period, particularly later, when the infants are 6 to 12 months old, is really high risk for both the infants and the birthing parents. Next slide. And we already covered a lot of the perinatal data content, but just of note, over 20% of deaths in the perinatal period. So this is looking at the pregnancy, the time of delivery, and usually to a year after delivery, can be attributed to suicide, so mental health concerns, to homicide, so interpersonal violence often, and then drug-related deaths, which is overdoses. And we know that families who have an infant who was diagnosed with neonatal abstinence syndrome or NOWS have a significantly higher risk of mortality from any cause, not just related to those three causes in the perinatal period. And we actually see that the number of deaths are most common in the late postpartum period. So those are those light blue dots in the graph on the right. These are U.S. overdose deaths, and you can through the years consistently the late postpartum period is the period of time where most overdose deaths occur. Next slide, please. And then this is looking at Massachusetts and Vermont. So I'll start on the right. This is looking at over 4,000 birth parents in Massachusetts, looking at timing of overdose, not deaths, but just overdose occurrence. And really showing that the least common time of overdose events is during the second and third trimester. And then really the most common occurrence is during the 5 to 12 months postpartum. And really pointing that out because that is the period of time when we stop seeing both birth parents and the infants as commonly. So we see them very frequently at the beginning, and then that care and this opportunities to come in and provide care decrease significantly as infants get older. The bottom graph from this study was looking at the differences in overdose events in birth parents who were on pharmacotherapy versus not. So the gray bars are the not in pharmacotherapy, and you can see a really significant difference in the frequency of overdose events when parents are not able to remain in pharmacotherapy, really highlighting the importance of supporting families and staying in treatment. I mean, on the left, we already covered a little bit of this data. The years for this graph are a little bit different, but you can see in Vermont, especially the blue bar is perinatal deaths related to overdose in Vermont, and the orange is within the United States. And on the right is when deaths occurred after 43 days of age. And so you can see we have a really significantly higher rate of deaths in the later postpartum period. Next slide, please. And a lot of this is related to increased risk for depression and anxiety. Overall, for all birthing parents, there's about a 10 to 15% risk of depressive symptoms at some point pre or postpartum. And then when we look at women who have a substance use disorder, over 80% of people are found to at times have some symptoms of depression or anxiety. And this is really important to identify because when people have underlying comorbid mental health disorders, they are more likely to stop treatment for opioid use disorder. And as I showed on the slide before, people who are not able to stay in treatment are much more likely to have overdose events and overdose deaths. It's really important to note that infants who have some withdrawal symptoms can be a lot harder to take care of. They can be fussy and similar to infants who have a period of purple crying, which we formerly called colic. It's just you're not sleeping. It is just a lot more challenging to feed and take care of those babies, and that in and of itself can exacerbate underlying mental health conditions. And a little bit unrelated to depression, anxiety, but women who have some substance use disorder are much more at risk of interpersonal violence. So when we think about underlying risks of homicide and then also depression and anxiety, those risks go up as well. Next slide, please. Um, and we covered a lot earlier thinking about fetal alcohol, but perinatal depression in and of itself has been found to impair bonding and development. So we know that when people have depression and anxiety, it's much harder to engage with those around you. And so when we think about parents who are trying to engage with their babies and babies who are developing interactions and learning how to interact with the people around them in that early period of time, underlying perinatal depression can really affect babies' ability to develop interactions with their family members and appropriate attachment, and it's also been associated with cognitive differences. And we also find that when families have depression, it is a lot harder to just get to your normal preventative health services. So infants whose parents have some perinatal depression are less likely to see their primary care providers and seek out or experience preventative health services. Next slide. Um, and we've touched a little bit on infant risk related to alcohol exposure, but similar risks are found in infants who have opioid exposure. So there are some significant neurodevelopmental differences that have been identified, and that means that these infants should have more screening based on AAP recommendations for developmental delays. And they're more likely to have behavioral issues and ADHD later on. And so, similar to having a fussy baby early on, it can be harder to parent these infants as they become children and enter school age. And so, families that really need some extra support. Families who have in utero substance exposures, the babies can have a harder time growing. They often can need some extra calories because of their symptomatology. Um, and then long term, they're more likely to be readmitted to the hospital. When we look at the time when non-accidental trauma or maltreatment is most likely to occur, it's actually between 1 to 7 months after the baby is born. And so this is this really important period of time, a little bit before the increase in overdose events seems to occur for birthing parents, but really shows that it's the postnatal period that is the highest risk, and sort of as we get farther out from the initial birth. Um, it's also known that infants are less likely to obtain all recommended well child visits and vaccinations. So a group that can really use additional supports in obtaining those. Um, and infants who have in utero substance exposures are at increased risk of mortality overall, and that is partially related to an increased risk of SIDS. And so really important that these families get really good education and reinforcement on safe sleep and tobacco exposure to help reduce those risks. Next slide, please. Um, and all of that said, we've touched a little bit on the barriers to obtaining follow-up care. It is really, really hard to coordinate getting care in the postpartum period. In part, we're in a rural area in Vermont for most of our families, and transportation is a really big issue, especially as gas prices and other things get more expensive. And then the care for the parent-infant dyad is often very siloed. So often parents are being asked to take their baby to the pediatrician separately to seek out their own postpartum care and health. And often these parents have other more complications to their pregnancies. And then often they may need to seek out their mental health care and sometimes even their medication-assisted treatment in separate places. And so that's up to 4 sometimes places that they have to go separately. And then sometimes they also have WIC appointments and other support appointments. So it can be really, really challenging to both keep track of all of that time-wise, as everyone knows, and also often each of these different individual groups are thinking about their individual patient, but not as the dyad as a group. And there is some evidence that for parents, when we think about them as a dyad and really focus on the interaction between the parent and the baby, there's actually better retention and care, and those sorts of interactions are more effective in reaching parents, making them feel supported. And so we have a lot of ways that we can think about how do we reduce siloing of care for our families. And then we've already covered often these families are coming to us with a significant amount of stigma that they've experienced previously in appointments. And so coming to see us to share with us that they need help is often a really scary thing to do. And they're also often very concerned about prior interactions with reporting and DCF, which we've also talked about previously during this conference as well. So families are coming to us with a lot of stress related to how they can share with us the things that they need help with. Next slide, please. However, all of that said, the perinatal period is a really exciting opportunity for us to reach families and to help improve care for them and help start to interact and provide long-term health for families. So when families are interviewed about kind of what motivators there are for entering and staying in treatment, becoming a parent and being pregnant is often cited for both starting to seek medication treatment for their opioid use disorder, for starting to set better boundaries if they have interpersonal violence in their relationship, for starting to think about financial health and supports, and really thinking about the ways that they can be the best parent they can be for their baby. And we also, as providers, have a lot of opportunities in this period to interact with families to help change their previous interactions and previous experiences that they may have had and their concerns about coming to medical providers for help. And so we have a lot of prenatal appointments. We have a full 96 hours usually with these families when they're admitted to the newborn nursery, or even longer in the NICU sometimes, to help provide and develop really strong relationships with their providers. And then often a lot of postnatal care that we also have opportunities in. So we have a lot of opportunities to really help these families and address many of the underlying barriers that they have to care. Next slide, please. So I'm going to transition into how home visiting can really address a lot of these high risks and barriers, and also think about screening families and provide long-term supports. Next slide. Thank you. And this slide really just covers a lot of what home visiting can do, but really a lot of focus on developmental and mental health screening, a lot of focus on providing developmental weight checks and teaching and helping parents learn how to be really good parents in terms of parenting skills, especially in the setting of having infants and children who may have more behavioral needs and so may need some extra support in that regard. And then a lot of teaching on safe sleep and breastfeeding and other safe and behavioral improvement interventions that we can provide. Next slide. And there is a lot of data on the benefits of home visiting for high-risk families, specifically for families with substance use, but for really just any families that are high risk, and focusing mostly on families with socioeconomic barriers, families with young parents, and other underlying mental health concerns. And overall, there is a lot of evidence that home visiting can help with better detection of underlying postpartum depression, with improving ER and physician visits for accidents and injuries. There's some evidence that it may make families more comfortable seeking out treatment, which is really what we want. So the actual number, when we look at ER visits, we in part want families to come into the ER when they're concerned and be comfortable doing that. But in some studies, they found some increased visitation for injuries, but actually less substantiated reports to CPS, which really implies that families are maybe more comfortable seeking out care, and there may be a lower risk of non-accidental harm to these families, or to these infants. We see better attendance at well child visits and better immunization rates, again, hopefully improved relationships with the medical care providers. And then just overall better nutrition, better positive parenting practices, and longer term, some evidence evidence for improved neurodevelopmental outcomes, especially reduced child behavior problems, because we can really address positive parenting and help with those concerns. Next slide. And when we look specifically at families with substance use disorder, there really is not as much work on this quite yet, but there is a lot of work publishing on barriers to providing this care and how do we develop programs, and some newer programs that are coming out that are really specifically focused on supporting families with substance use. Assisted treatment within the home. As far as I know, that's not generally available within Vermont. But these programs often focus on peer support and are showing evidence that the peer support model is really what is beneficial for these families in a lot of contexts. There's no real national guidance from larger organizations on exactly what should be provided in terms of home visiting services. Ideally, visits begin prenatally. And when we look at sort of the focus on discharge supports for infants with in utero substance exposures, there are clear discharge checklists and clear evidence that we should have a good discharge checklist. There's not been a body that specifically said these infants really should have a referral, but it's on most of the discharge checklists when we look at the places who are providing input on how that should look. Next slide, please. And we do also have a lot of evidence that home visiting is really beneficial for screening, specifically for perinatal mental health. When we look at how good we are as healthcare providers at screening families for mental health disorders during the perinatal period, we really are not doing a very good job nationally. So the data from 2019 to 2021 nationally for Medicaid patients is that only 16% were screened during the prenatal period, and the data for postnatally is even less. And when we look at privately insured patients, it's even less, so 9% prenatally and even less than that postnatally. Great mechanism for screening families. It also has been found to improve referrals to mental health providers nationally. Many programs have found some decrease in depression and anxiety symptoms, but importantly, most home visiting providers are not trained in treating mental health conditions. And so that's not really their focus, but they are screening and referring. And there is more ongoing work really focusing on how do we develop and improve providers' ability and comfort in addressing mental health concerns within the home when they go and do these screening tests. Next slide, please. And so now I'm going to transition to talking about what are we nationally and specifically in Vermont to really support these families and provide home visiting. Next slide. So to do that, I really want to just start by clarifying what is home visiting and what is home nursing. So home visiting very specifically is a preventative supported service. All newborns qualify for this. And so when I talk about the data for home visiting, this is really what we're talking about. But this provides screenings for mental health, screenings for interpersonal violence and substance use. It provides case management, so helping make sure families are connected with the care that they need, provides goal setting for families, and connects them with help and developmental education and parenting supports. When families, particularly the birth person or the infant, have a specific nursing need, so for example, lactation supports, weight checks and blood pressure checks, they then need specifically a skilled nursing referral. Importantly, the same agencies provide both of these, so families that get a skilled nursing referral will also get the preventative supportive services. That's not always the case with lactation, because sometimes lactation is managed slightly separately, and so in that setting, a separate referral is good, and we'll talk a little bit more about that. But generally, the same agencies are providing this care and evaluating families and determining what they need, and so a referral to any agency will get the preventative referrals that we want families to be having. Next slide, please. Sorry, next slide. And so federally, there's actually a lot of support for home visiting, which is really exciting. So as part of the ACA in 2010, the MIECHV program was funded. It was recently refunded for an additional 5 years in 2023, and so is covered for the next few years at least. And what this group does is provide funding and distribute funding to states in order to provide evidence-based home visiting for high-risk families. And usually through about 2 years of age, so starting prenatally and then postnatally. And as part of this, there is a group of researchers who form the Home Visiting Evidence of Effectiveness group, and they have reviewed now, I believe, 74 different programs or approaches to home visiting. And of those, they've identified now 27, but there's 24 that are sort of within the MIECHV so far that have been proven to be evidence-based approaches to home visiting that are being implemented and funded nationally. Next slide. And so within Vermont, two of these evidence-based programs are used. The first is the Maternal Early Childhood Sustained Home Visiting Program. This provides 22 to 25, 60 to 90-minute home visits that continue through the child's second birthday. So through that really early period, but really also including that postnatal period, getting closer to a year of age that families are at higher risk. And what this provides is parent education, developmental screenings, support for parent-child relationships, maternal health and well-being support, and support for housing and finances. And when we look at the areas that have been evaluated for whether or not this program is effective, it has strong, high quality or moderate quality evidence of benefit in maternal health, child and school readiness, child health, especially in SIDS knowledge and breastfeeding duration, and in positive parenting practices. Next slide. And the other program that is provided and offered in Vermont is Parents and Teachers, and this is one of the more commonly provided programs across the country, has a very strong evidence base, and this provides at least 12 home visits annually, but importantly also helps support parent group connections. And I said earlier that group connections and peer support have been identified as really being beneficial for families with substance use disorder. And so this program provides a certain amount of that, not specifically for substance use, but also provides developmental screenings and connections to community resources. And so what this is providing as evidence for is improved child development and school readiness, positive parenting, and family economic self-sufficiency. And it doesn't mean that it's not providing a lot of other benefits. This is just what has been identified in the literature as being clearly established as having high quality or moderate quality evidence. Next slide, please. So when we look at what is happening in Vermont in terms of home visiting programs, the MIECHV collects a lot of variables on what is being provided specifically to families, and then on how Vermont is doing in terms of providing screening and support for families as well. So we have 2024 data most recently. And so in 2024, there were 462 households that were served through this program for a total of over 3,500 home visits, and 25% of the families had a history of substance use identified. Over 90% were identified as having socioeconomic challenges, so being under the 200th percentile for the federal poverty level. And then we see a lot of families with an underlying history of child abuse or neglect, which obviously also makes obtaining care more challenging. Next slide. And when we look at the performance measures that MIECHV is visiting, and so this is really looking at how well are we doing with screening and providing support. For these next three slides, these measures are presented in this arch, and this is 2024 information. The blue is how Vermont is doing in terms of the data that they provide, and the green is the orange is the national data. And so the top left on this one is looking at child maltreatment, or a little bit, this is one where you would want to be 0. And then the other three, we would like to be at 100%. So we are doing very, very well with infants receiving their well child visit follow-ups. We're doing well with safe sleep education, which has been at about 80% for the past few years for these families. And we're doing reasonably well, close to the national on breastfeeding, but obviously we would like this to be closer to 100% for families who are receiving any breast milk at 6 months of age. Next slide. And then this is looking at how we're doing in terms of developmental screening and activities for infants. So the top left is looking at, was there any observation of a caregiver-child interaction by the home visitor using validated tools? So are we screening families for how they're interacting with their babies? And almost all families are receiving that. We're doing significantly better than the national average on that. This image below that is looking at our developmental screening, which we're not quite at the national average for that, but about 70% of families are receiving some developmental screening. On the right from that, the bottom right is looking at how many developmental referrals are we placing. And so that is the infants who screen positive, are they then getting referred? And a little over 50% of infants are. It's another place that we could potentially improve. And then when we look above that, we see that over 86 or 80% of families are reading to their children, singing to their children, or having a good positive developmental interaction in terms of literacy and language with their infant on a daily basis. So that's really good evidence. Next slide, please. And then when we look at how we're doing with maternal screening, we see that a large percentage of our birth parents are seeing postpartum care within 8 weeks of delivery, and so that is what is recommended. We are referring a huge number of families to intimate partner violence referrals when they need that. So almost 100% of families who are screened for having some intimate partner violence are getting referred. When we look at depression screening, we're meeting the national average, and about 83% of our caregivers are being screened. And of those who screen positive for some depressive symptoms, almost 60% are being referred for follow-up services. Next slide. And so that really covers the value of getting families into screening and how we're really providing good care in our home visiting programs. And so now maybe wondering, how do I get this to families? And so I'm going to cover now sort of what we can do to get families home visiting. Next slide, please. And so how we get families there really depends on what kind of need that they have. If families need a specific skilled nurse need, so that's a weight check, a blood pressure, or if you're kind of in doubt, putting in a medical referral is always fine and is valuable. That will get a skilled nurse. A medical referral needs to be placed by a physician or a nurse practitioner or a PA generally, although it can be sometimes placed by a nurse and co-signed. And that will get to the agencies for the general preventative support, which is really the goal as well, and all families should get that. There are lots of routes to place the referral. So a medical referral will also get families the home visiting support. You can also refer through Help Me Grow, or if you already have a established referral mechanism within your organization, just go with that if you know that it is working. So it's fine to directly refer to organizations and home health agencies in that way. Anyone can place a referral to Help Me Grow. So if there's someone in the community and you want to help them, this can also be a self-referral. And then again, if you just refer directly to agencies, that's also wonderful. It really doesn't matter. The goal is to get a referral in the door to an agency, and then an agency will call. They'll discuss with the family what the next steps are, and they'll make sure that the services that the family needs are being provided. Infants with NOWS or NAS do qualify for a medical order. So if you're a community pediatrician or discharging from a community hospital, it is fine to put in a medical referral, even if that baby doesn't need weight checks or something specialized. You can put NOWS on the reason and the diagnosis in that referral, and that will get them to care. And really the goal is to refer as early as possible. So if you see a birth parent who is prenatal, get them in the door if you can. But really at some point, ideally, they will get some preventative care through home visiting services. Next slide, please. And as we've been going through our quality improvement work that I'll talk about next, we've come up with some really common questions that we've encountered as we've looked at this process, because ultimately the process is really confusing. So the first has really been, we're seeing a lot of people place a lactation referral and then concerned that the family also does not qualify for a home visiting referral or feels like that's not necessary. But we really encourage having a separate referral for the baby when a lactation referral is placed. Sometimes the family will choose not to breastfeed and then not pursue that lactation referral. And then again, sometimes lactation referrals are to a different sort of a lactation specialist in the community. Doesn't always go through the home health agency. So please also place a referral for the baby in that situation. Um, and families have home health prenatally. We also would like a referral placed postnatally for the babies because sometimes something can happen with that referral, or the families think a referral is. Families sometimes think that a WIC referral is a home visiting referral. And so it's really valuable to just have a separate referral placed to make sure that everything is getting placed. We've had situations when families are living at Lund or another residential facility, and there are usually services that are preventative provided by the nursing associated with that facility. So often the referral is not needed, but that's not always the case, and sometimes families will move out. So having that referral in place is still really important. If it ends up being redundant, all that will happen is that the agency will discuss with the residential facility and figure out what resources can be provided. And if it's everything is being covered by the residential agency, the nursing agency will close out their referral. Families who are in foster care or have been adopted out or have some DCF support or involvement also still should have a referral. This is really important because these babies are at higher risk of neurodevelopmental differences. And so the extra screening that happens is really valuable and important. And often families are reunited with their infant, and so then having that referral and support in place is really valuable as well. And then families who are worried about costs, this often comes up where, particularly when families have private insurance, they're worried about getting charges. And so really to reassure families that nothing will happen until the agency has run the family's insurance, evaluated care that's available for their insurance, and then had a conversation with the family about what's available. So a referral really just results in a phone call, no charges happen. It's just a way to get the families in the door, and then a conversation will happen between the home visiting agency and the family about what can be provided and covered. So really, when in doubt, place the referral. There's no harm in placing a referral, and it really just gets families in the door and provides them with a connection. Next slide, please. So with all of that, I'm going to transition to briefly covering the work that we've been doing at UVM, trying to improve our referrals for families with in utero substance exposure. So next slide. And so this is our quality improvement team. So again, many of the members of VCHIP have been working on this project. We also have Katie Leffel, who has chimed in earlier on this and has been a really amazing resource. We have all of the social workers on our newborn nursery and NICU, and then nurses representation from both our newborn nursery and NICU and from VCHIP. So next slide, please. And our goal in this project is to improve our referrals placed at the time of discharge for all infants who have had in utero substance exposure, really specifically opioid exposure for this project. But obviously, all infants would benefit from a referral. At the time of discharge from the newborn nursery or the NICU is when we are trying to make sure referrals are placed. Next slide, please. And initially, when we started to look at our process within the hospital, we noted that the process was incredibly confusing. Essentially, the referral could be placed by the infant's provider, by the infant's nurse, or social workers. There were multiple avenues for placing a referral, ranging from a medical order to a phone call to a fax. And we were only actually referring about 27% of families to home visiting. And initially, it was extremely challenging to even figure out if families were having any discussion of home visiting during their admission, because we really had a very consistent lack of documentation of any discussion at any point. Next slide. And we as a group over the past about 2.5 years have gone through multiple PDSA cycles. And so the process that we have settled on at this point is that we have developed a electronic family care plan template, which hopefully ultimately this will become something that is done prenatally and through the process that the plan of Safe Care Family Care Plan group is working on separately. But for now, we are now documenting all of our family care plans through Epic, and then it can be easily transmitted to the PCP that way. We have transitioned to opt-out language, representing home health and home visiting, and really presenting this and doing a lot of education with our nursing and other staff standard of care for infants with in utero opioid and other exposures. To help facilitate the conversations our staff is having and to help facilitate the opt-out discussion, we've developed a handout that explains what home visiting is and the process of the referral and uses opt-out language for families. And then we have made a decision within our institution to simplify the ordering process. And although a phone call to agencies technically works to get the preventative care, we've said we really want to just make it one provider group that is responsible for the referral and one approach to placing the referral. So we're asking that all infants have a medical order placed for the babies at the time of discharge to really just try to streamline and simplify our process. Next slide. So this is the handout that we've developed for our family, and the credit for this design goes to soon to be Dr. Nicholson, who really developed a beautiful handout that we got a lot of parent input on as well. And we are now giving this to all families with substance use and any other family where the providers feel like it would be helpful. And it really outlines general benefits of home nursing, what can be provided. And then you can see I circled down here that we have put the opt-out language on this handout, saying that we'll automatically make this phone call. On the left, we felt like it was really important to cover, and from feedback that we got from families, that all that happens when a referral is placed is that a phone call is made. The timing of the visit, the requirement of the visit, that's all up to the families, and that nursing can actually meet with families at whatever location, a playground, a cafe, that is comfortable for families. Next slide. So it just really quickly, we've seen a really good transition in our referrals. So for people not as familiar with run charts, what this is showing is the number of referrals that we've managed to place over time. So each dot is 5 babies who were cared for in the NICU or newborn nursery. We started our data collection starting in August of 2022. And when we've made these changes, so over on the right, you can see we've shifted up to now a medium of 60% of our families have a referral place at discharge. And we've really stabilized at 60% and occasionally gotten to 100% in each 5 baby group that we've been looking at. So seeing a really significant improvement with our interventions that we've made. Next slide, please. And this graph is, I know, a little bit confusing, but it's really just showing that of those referrals, we're also seeing a lot more medical orders placed. So all of the yellow diamonds are just overlaying what percentage of those referrals were medical orders. And so you can see at the beginning, it was very all over the place. And now we're starting to see about 40 to 80% of the referrals placed are medical orders. So we're not at 100% medical orders. We're still having some phone calls being made, but with which is great. We're happy to have a referral placed in any way, but our hope is that 100% of these will be medical orders going forward. Next slide. And then this has really been work from our social work colleagues and showing that we're really at almost 100% of our families being discharged with a family care plan documented. So we've stabilized at about 80% and are sometimes 100%. This is a little bit complicated because when we have families who are in foster care or have DCS custody, often they're doing a lot of the safety planning. But our hope is that these families still would have a family care plan going forward at discharge. So we've made a ton of progress on that, as you can see. Next slide. And the things that we've really learned through this process, obviously, as in all QI work, a multidisciplinary team is always essential. We found that our EHR templating for our family care plan has been really, really helpful. It we have not found that it increased work and hopefully has decreased work for our social workers because they are really able to do a lot of the screening that they did separately before within the template. And then it makes it really easy for it to go forward to the PCPs and get sent along. So the opt-out language has really changed the way that our staff is discussing referrals with each other and with families. And the medical orders has really simplified the process for taking away a lot of the confusion about how we put these orders in. Next slide. We did, as I was doing a lot of the education and making this opt-out transition, identify a lot of concerns that our staff had in transitioning to opt-out language. And a lot of that came from our hope to really provide as much autonomy and control for families as possible. Many of these families, of course, have underlying interpersonal violence and a history of trauma. So we really want to make sure that they have complete autonomy and control over their medical care going forward. And we really address this by helping providers shift their thinking about this as standard of care for newborns. This is really similar to the expectation that families attend well-child checks and specialty follow-ups. And we found that when we really shift to thinking about this as standard of care, which it is, um, it really makes a lot of sense to just use opt-out language. The way that we recommend phrasing that is saying we recommend nurse home visiting and home visiting for all families. With newborns, it provides extra developmental screening and support. And we really recommend this. And then we give families the opportunity to say, no, I don't want that, rather than saying, do you want home health? Some families find it really helpful. So it's really just that frame shift. Um, and then we really emphasize that a referral does not require any further follow-up or follow-through. So the family always has the agency to choose. I'm not going to answer the phone. I'm going to say, actually, I don't want this, or say, I don't really want someone coming into my home. And that's always a completely fine decision. Does not result in any necessary follow-up with, it's not a thing that would result in a referral to DCF or anything like that generally. Next slide. And so in conclusion, just to summarize, the perinatal period is really high risk, especially as we get farther out from the delivery. Every medical interaction we have with families is an opportunity to engage them with care. And home visiting really provides an evidence-based opportunity to improve our screening, developmental education, and parenting education with families, and just provide them overall extra supports. And then in our quality improvement work specifically, we found that simplifying the referral process and this transition to thinking about this as an opt-out presentation to families has really been a huge improvement in the way that we've been able to provide referrals. And next slide. I think that's it. Uh, yeah, thank you all for listening, and I will take questions. We have a group email, the prenatal preparation for nows, because I will lose access to my email address soon. But we're happy to take any questions and share our resources. We're hoping that some of what we've learned as a organization can help other community hospitals and other providers improve their ability to provide referrals for families in all contexts.
Thank you so much for your presentation. I do see a question in the chat that I know you know the answer to. Of the percent of referrals placed, how many families actually engaged in these services? I know you did some work to evaluate that.
I'm still, there's still some families that I haven't gotten follow-up on, but I have gone through and looked in the charts for sort of the 200 babies that we have information on, and somewhere around 65 to 70%. So I'm still gathering information. So that's of the babies who had a referral, which is about 80 families or so, excluding some of the New York babies because we're not actually able to follow up with the organizations there as easily as our Vermont organizations. So I didn't say earlier, but this our data for referrals is including New York families as well. But then when I'm looking at the follow-up, I'm not able to tell for some of the New York ones. But generally, about 65 to 70%, which I think is a really great number. And we see a lot of these families really coming back. I can tell from our NICU follow-up clinic notes that a lot of families are identifying this and continuing to follow up with home visiting long-term because we have those notes going forward. They're followed often for the first year or two of the baby's life.
It sounds like a net increase overall in terms of the percent of families engaged with home visiting and likely engaged in all of these screening activities and this extra support, which is wonderful.
We're really excited for that.
So another question in the chat is about whether there are any challenges making referrals to agencies outside of Chittenden County. And you kind of mentioned New York as one
Yeah.
challenge.
New York is a bit of a challenge because their system isn't as oriented to um, combining the preventative services with their skilled nursing. And so for New York, it is a very separate referral if families need skilled nursing, and there often in some regions isn't skilled nursing available. And sometimes there isn't right now in a couple counties the preventative services available either. And so whereas in Vermont, we've been able to establish that if we place the medical order for a family, they'll then get that preventative service as well. In New York, that's not always the case. And so it's a little bit harder to connect them. We have not had outside of Chittenden County, though. Katie has done an amazing job of helping reach out to sort of all organizations as we've made progress through this process and thinking about the process. And so, as far as I know, I haven't noticed any sort of dropped referrals based on other counties at all. Adrian, I think you're muted.
Thank you. I was just asking if there were any other questions or comments and encouraging other people to unmute.
Hi, this is Katie. I put it in the chat, but I just thought I might as well unmute and say it too. We've been doing a lot of work on the family care plan virtual template, which a lot of people know about. It's not it's not rolled out yet, but it's pretty close. And that virtual platform was based very heavily on the Epic family care plan template. So just encouraging people to know that that resource that Julie was talking about in the presentation is going to be available on that virtual platform, and that can be downloaded and uploaded into a EMR. So that same kind of comprehensive and thoughtful approach to all the resources is going to be available pretty soon this year anyway.
And I think about and I'm happy.
Hello, Jennifer Aletta here again from CVMC. Can you hear me okay? Again, I'm lost in Epic new video issues, so I can't get on. My camera's currently not working. I wanted to just put a total celebration of our home visiting teams across counties, especially for families who are homeless, where we have had to discharge people who are maybe currently in a motel or using up their 80 days or in various other challenging housing situations. They might deliver here in central Vermont, but then when we're discharging them and they don't necessarily have a place to go, when we have had to call 211 or reach out and they've gotten housed in other counties. We've had a small handful of this just in the last year or so, less even. I was able to contact Michelle Dane, my home visiting person, nurse manager for Central Vermont, and she got me in touch with someone in Chittenden County, and then we were able to have nursing follow up with a motel in Chittenden County that this family ended up being at, and they were able to arrange other pediatric follow-up and support. So just feeling that our communication across home visiting teams in different counties is strong, and just really, really appreciate that so much.
Thank you for sharing that. Well,